Hello and welcome to my channel. In this lecture we'll be talking about the axilla, so let's begin. The axilla, it's this region where the armpit is. It's conical in shape and opens to the neck through the cervico-axillary canal. The boundaries of this canal medially is by the external border of the first rib, laterally by the coracoid process, anteriorly by the back surface or the posterior surface of the clavicle, posteriorly by the superior border of the scapula. The base is the armpit. It's convex because of the tension of the axillary ligament, suspensory ligament of the axilla, the continuation of the clavipectoral fascia, and the base is formed of skin and axillary fascia. The anterior wall is by the pectoralis major and minor muscles. The pectoralis major forms the anterior axillary fold and also the clavipectoral fascia. We studied the clavipectoral fascia earlier. Posterior wall by the subscapularis muscle, teres major, and the latissimus dorsi. The latissimus dorsi forms the posterior axillary fold. The medial wall is convex. It's the thoracic cage with the serratus anterior on it and the intercostals. The lateral wall, remember the insertion of the pectoralis major and the latissimus dorsi and teres major, they all converge to the bicipital groove. So the lateral wall is narrow. Has also in the lateral wall the coracobrachialis and biceps brachii muscles, especially the short head of the biceps brachialis, biceps brachii muscle. The contents of the axilla, the axillary vessels, the axillary vein, and the axillary artery. The vein is medial to the artery or anteromedial to the artery. Cords of the brachial plexus, as you can see here, and their branches. Lateral branches coming from the intercostal spaces, the nerves. They are called the intercostal brachial nerves to supply the armpit, especially from the second and third intercostal spaces. Axillary tail of the breast, as we studied before in the thorax, and lymph nodes, the axillary lymph nodes, we will study them in details. Now, incisions in the axilla should be at the base, midway between the anterior wall and the posterior walls, so as not to cause nerve and vessel injuries, and nearer to the medial wall to be away from this bundle of vessels and nerves. Okay, away from the axillary vessels and nerves. The axillary artery begins at the outer border of the first rib as continuation of the subclavian artery, ends at the lower border of teres major by becoming the brachial artery. The pectoralis minor muscle crosses it. The pectoralis minor, this is the cut part of the pectoralis minor. It crosses the artery, so differentiates the artery into first part, second part under the muscle, third part beyond the muscle. And this is the way we're going to study the axillary artery. The first part, which is the part proximal to the pectoralis minor, it's together with the axillary vein and the brachial plexus in the axillary sheath. Anteriorly, there is skin, fascia, platysma muscle, supraclavicular nerves, the lateral group, deep fascia and pectoralis major, clavicular head, and clavipectoral fascia. It's crossed by the lateral pectoral nerve because it's coming from the lateral cord. It crosses the artery. The cephalic vein on its way to drain into the axillary vein, and the thoracoacromial vessels, which is a branch of the second part of the axillary artery. Laterally is the posterior cord. Now remember, doctors, please, when the artery descends, in close relation to the cords of the brachial plexus, First, it crosses the medial cord. So the medial cord is a posterior relation to the first part. Then in the second part, with further descent of the artery, it becomes in the middle, you know, the lateral cord lateral, posterior cord posterior, and medial cord medial. In the first part, the posterior cord was lateral, still lateral, before the complete descent of the axillary artery. So it's laterally, it's the posterior cord of the brachial plexus. Anteromedially is the axillary vein, and posteriorly is the first space and intercostal, the first two digits of serratus anterior muscle, the long thoracic nerve, the medial pectoral nerve, and the medial cord of the brachial plexus. These are the relations of the first part. You know, it's better to understand the relations rather than learning them by heart. The second part of the axillary artery, this is the second part of the axillary artery. Anteriorly, we have skin, fascia, and pectoralis major and minor muscles. Posteriorly is the posterior cord now of the brachial plexus. So the cords are named after the relation with the second part of the axillary artery. Laterally is the lateral cord of the brachial plexus and coracobrachialis muscle. See, medially is the axillary vein separated by the medial cord and medial pectoral nerve. Medial cord and medial pectoral nerve. Now lower down, the medial cord with this will disappear, and these medial relations will be replaced by the medial cutaneous nerve of forearm and the ulnar nerve. Okay? Now the third part, anteriorly also skin, fascia, pectoralis major, and medial root of median nerve. See the medial root of medial nerve. Well, to your surprise, I had a question before in the FRCS exam, which is longer, the medial root of median or the lateral root of median. They are testing your knowledge that the median nerve first was on the lateral side of the artery, so the medial root must be longer than the lateral root of the median. Well, you will not encounter this type of questions in American exams like the USMLE. Posteriorly to the third part is the lower part of subscapularis muscle, tendons of Latissimus Dorsi, and teres major muscles, radial and axillary nerves. Now the posterior cord disappeared because only the branches remains. Laterally is the coracobrachialis muscle, the lateral root and trunk of the median nerve, and musculocutaneous nerve. This is the musculocutaneous nerve here. Medially is the axillary vein. See, and the medial cord now is replaced by the medial cutaneous nerve of forearm and the ulnar nerve between it and the vein. Remember that the medial cutaneous nerve of arm is medial to the vein, while the medial cutaneous nerve of forearm and the ulnar nerve between the vein and the artery. Remember that. So the medial cutaneous nerve of arm is the most medial structure. Now, branches of the axillary artery, since it's first part, second part, third part. The first part, 1 branch, second part, 2 branches, third part, 3 branches. It's easy. The first part, 1 branch, superior or supreme or highest thoracic artery. This is the highest thoracic artery. It goes to supply the sternoclavicular joint and the subclavius muscles. Small and runs along the upper border of pectoralis minor, lower border of subclavius and supplies, anastomose with branch of the internal thoracic and intercostals. The second part, though it's showing here that branch of the second part is above the pectoralis minor, actually it's behind the pectoralis minor. The thoracoacromial artery, it gives branches A, P, C, D. The acromial, the pectoral, the clavicular, and deltoid branches. behind, then above the pectoralis minor, gives acromial, pectoral, and clavicular and deltoid branches in deltopectoral groove. The lateral thoracic artery, the one you see here, this is the lateral thoracic artery, along the inferior border of pectoralis minor, and in thoracic wall, ends in thoracic wall anastomosis, and enlarges in the female breast, especially during, also enlarges furthermore during pregnancy in females, because it's the major blood supply of the breast. From the third part, we have the subscapular artery. It's large, but immediately of short course, and immediately divide into circumflex scapular and thoracodorsal. The circumflex scapular artery, this is the circumflex scapular artery. It goes through the triangular space between the subscapularis above, teres major below, and the long head of triceps laterally. Okay. It winds around the scapula, anastomose, shares in the anastomosis of the scapula, around the scapula to supply the shoulder joint. It continues the subscapular artery as thoracodorsal, descends with the thoracodorsal nerve to the latissimus dorsi, and anastomose with the lateral thoracic and intercostal arteries. Anterior and posterior circumflex humeral, from the name, they wind around the neck of the surgical neck of the humerus. This is the anterior circumflex humeral artery, passes behind the coracobrachialis and heads of biceps brachii, gives, of course, branches to humerus and shoulder, and anastomose with the posterior circumflex humeral artery. Now, the posterior circumflex humeral artery is bigger, okay, and lower down. So you differentiate this in X-rays by identifying, because the X-rays are two-dimensional, they are not three-dimensional. So the bigger artery is the posterior circumflex humeral artery. Pass in the quadrangular space between the capsule of shoulder, subscapularis and teres minor above, below the teres major. Laterally is the surgical neck of the humerus, and medially now is the long head of triceps. This is the quadrangular space. You should know the boundaries of the quadrangular and the triangular spaces. It supplies the shoulder joint and the surrounding muscles, and anastomose with the anterior circumflex humeral artery. Now, to control bleeding in the arm, you compress the axillary artery laterally, because of the, the anatomy now. You compress it laterally to be against the humerus to stop the distal bleeding. Okay? Also, the axillary artery is liable to injury in shoulder dislocation. But the most structure liable to injury in shoulder dislocation, because shoulder dislocation commonly is anteroinferior, so the axillary nerve is liable to injury in shoulder dislocation. The axillary vein starts at inferior border of teres major. Now we're going on the opposite direction. Becomes the subclavian at the external border of the first strip, and medial to the axillary artery. As we learned before, the medial cord and medial pectoral nerve in between proximally, and distally medial cutaneous nerve of forearm and the ulnar nerve now between the artery and the vein, and the medial cutaneous nerve of arm is medial to the vein. Okay, and the lymph nodes is medial. Lymph nodes are medial to the vein as well. Lymphatics in the axilla. Axillary lymph nodes in the fascia of the axilla. They are divided into groups. Apical group, medial to the vein, all medial to the vein, by the way. Medial to the vein, drain all other groups to the thoracic ducts, either on the right or the short thoracic duct on the left, either on the left or the short thoracic duct on the right. The lateral group, posteromedial to the axillary vein, medial group, and they are divided into anterior and posterior groups. Anterior are pectoral group, drain thoracic wall and breast. Posterior are the subscapular, called the subscapular group, along the subscapular artery. The central group in the middle receives from the medial and lateral walls, or medial and lateral groups, and sends to the apical group. The central receives from the medial and lateral groups, then sends it to the apical group. Okay? Now the brachial plexus. It's formed by the union of the ventral primary rami. Remember, dorsal rami do not form plexuses. Only the ventral rami form plexuses. So it's formed by the ventral rami of C5 through T1, and may be shared with C4 and T2. It's divided into roots, trunks, divisions, and cords. Now the roots and trunks, they ask about that. The roots and trunks are above the clavicle in the neck, the divisions behind the clavicle, and the cords in the axilla. So if we are studying the axilla now, we'll be dealing with the cords of the brachial plexus. Okay, now the C5 and 6 form the upper trunks. The C5 and 6 roots form the upper trunk. The C7 root forms the middle trunk, and C8 and 1 forms the lower trunk. Okay, lower trunk that arches over the first rib. The trunks divide into anterior and posterior divisions. The anterior divisions of the upper and middle trunk form the lateral cord. The anterior divisions of the lower trunk form the medial cord, and the posterior divisions of all trunks form the posterior cord. You should know this organization of the brachial plexus. And of course the cords named after their relation to the second part of the axillary artery. The supraclavicular branches means from the roots and trunks. There are no branches from the divisions. Nerves to scaleni and longusculi, see that? Scaleni and longusculi muscles of the neck. C5 branch to the phrenic nerve. Remember the root value of the phrenic nerve, C3, 4, and 5. This is the share from the brachial plexus. The rest of the phrenic nerve from the cervical plexus. The dorsal scapular nerve, or nerve to rhomboids, C5, it pierces and supplies the levator scapulae and pierces the scalene medius and ends in rhomboids. The long thoracic nerve, C5, 6, 7, this is the one that descends behind the roots. Yes, learn that. Behind the roots. Descends behind the roots. It's to the serratus anterior muscle, supplying each digit until inferior border of the muscle. Now from trunks, we have nerve to subclavius. C5 and 6 descends anterior to the brachial plexus, nerve to subclavius muscle. So the nerve to subclavius is anterior to the brachial plexus. The long thoracic nerve is posterior to brachial plexus, posterior to the roots of brachial plexus. And the suprascapular nerve, remember the one that passes in the suprascapular notch, bridged by the transverse scapular ligament. Above it is the artery, separated by the ligament. It passes deep to trapezius, then the suprascapular notch, inferior to the transverse scapular ligament, and supplies supra and infraspinatus muscles. Pardon me. Infraclavicular branches from the cords. The lateral cord branch is the lateral pectoral nerve, C5, 6, and 7. Lateral pectoral nerve. It communicates with the medial pectoral nerve of the medial cord. Gives a loop to it and shares it. Pass anterior to the axillary artery on its way medially. It crosses the artery, remember. Crosses superficial to the artery, not deep to the artery. And above the upper border of pectoralis minor, it supplies the pectoralis major, pierces the clavipectoral fascia, remember that? The musculocutaneous nerve, C5, 6, 7, pierces the coracobrachialis, lies on brachialis, covered by biceps, remember that. Pierces coracobrachialis, lying on the brachialis muscle, covered by the biceps muscle, and emerges from the lateral border of the biceps brachii muscle as the lateral cutaneous nerve of the forearm. So it supplies the forearm as well. Supplies muscles and skin, that's why it's called musculocutaneous nerve. And the lateral root of the median nerve. Okay, lateral root of the median nerve. This is the lateral root of the median nerve. Okay. The medial cord gives the medial pectoral nerve, C8 and T1, passes posterior to the axillary artery. This one passes posterior, not superficial or anterior. Then between the artery and the vein, and joined by a loop from the lateral pectoral nerve, pierces and supplies the pectoralis minor, then ends in the pectoralis major. Remember the supply of the major, lateral, and medial pectoral nerves. We have the medial cutaneous nerve of the arm, or medial brachial cutaneous nerve. It's medial to the vein. We have the medial cutaneous nerve of the forearm, or the medial antebrachial cutaneous nerve. It's between the artery and the vein with the ulnar nerve and the ulnar nerve. Okay. And the medial root of the medial nerve. These are the 5 branches. There are 3 branches from the lateral cord, 5 branches from the posterior cord, 5 branches from the medial cord. Now the posterior cord of the brachial plexus. You should know the branches in order. Means upper subscapular, then thoracodorsal, then lower subscapular, then axillary and radial. The upper subscapular is to subscapularis muscle. You can see the branches here, the upper subscapular. The lower subscapular nerve is this one, the thoracodorsal is this one. The upper subscapular to subscapularis, the thoracodorsal nerve runs in subscapular with the subscapular thoracodorsal branch or thoracodorsal artery, ends in the latissimus dorsi muscle. Lower subscapular to subscapularis and the teres major muscles. The upper and lower subscapular branches very frequently to find them as multiple branches. They are not only one branch each. The axillary nerve, or called the circumflex humeral nerve, as you can see here, this is the left shoulder. This is anterior, this is posterior. The deltoid muscle is reflected, as you can see here, and you can see the branches of the axillary nerve. Okay? The axillary nerve at inferior border of subscapularis muscle below the shoulder. I told you before, it's more liable to injury in this location. Runs with posterior circumflex humeral artery in the quadrangular space, then divides into anterior and posterior branches. Now the anterior branch continues with the posterior circumflex humeral artery and supplies the anterior part of the deltoid muscle. The posterior branch supplies the teres minor and posterior part of deltoid, and then emerges on the skin to become the upper lateral cutaneous nerve of arm. Remember, the upper lateral cutaneous nerve of arm is a branch of the axillary nerve, while the lower lateral cutaneous nerve of arm is a branch of the radial nerve, okay? Supplying the skin at the lower, over the lower part of the deltoid muscle. The radial nerve, posterior to the third part of the axillary artery and brachial artery. It runs with the profunda brachial artery in the radial groove on the back of the humerus. Remember the radial groove? The radial groove itself is covered by the lateral head of the triceps muscle. Pierces lateral septum, becomes between brachioradialis and brachialis. Anterior to the lateral epicondyle, it divides into superficial and deep branches. And we will discuss the branches of the radial nerve when we study the arm muscles, and furthermore when we study the forearm. Okay. Now there are some lesions on the brachial plexus, and mostly happen in either in faulty deliveries, difficult deliveries when the doctor pulls hard on the arm, or the arm become impacted over the head of the fetus, for example, or also common in motorcycle injuries. We have what's so-called the Erb's paralysis, involves mainly C5 injury, so it's an injury to the upper part of the brachial plexus. Injury to C5 will result in paralysis of deltoid, biceps, brachialis, coracobrachialis, supra and infraspinatus muscles. So remember, when you cut the roots, complete loss of abduction at the shoulder. But when you cut the axillary nerve itself, there is no complete loss of abduction because the supraspinatus is still healthy. The nerve supply is still healthy, which is not axillary. Okay? It's the suprascapular nerve. Okay, so the arm becomes abducted because there are no abduction, pronated because no supination, and extended because there's no flexion at the elbow. So this gives, it's a weird way to name the deformity, the waiter's tip deformity, as if the waiter is, shy to ask you of a tip, and so he, pronates his arm and not looking and asking you for a tip, whatever. So it's called the waiter's tip deformity. Klumpke's paralysis, it's injury to the lower part of the brachial plexus, lower roots and trunks of brachial plexus, C8 and T1. This happens when the arm becomes impacted over the head of the fetus and the doctor continues its pull on the fetus to deliver it. Okay? This will make traction on the lower part of the brachial plexus. This will lead to paralysis of the flexors of the wrist, the intrinsic muscles of the hand. Okay? This is called the Klumpke's paralysis. Another deformity, which is winging of the scapula, in injury to the long thoracic nerve, especially if in incision of the axilla very close to the medial wall. Remember, the incision of the axilla must be away from the medial wall to avoid injury to the long thoracic nerve and the thoracodorsal nerve as well. The dead limb, in severe injury in which there is avulsion of the roots. The upper limb becomes hanging, and there is no use of it. Usually the patient refuses amputation, but few days later, when the limb obstructs him, becomes in his way, he comes back to you and asks for the limb to be amputated. Axillary nerve paralysis, as I told you before, there is no complete loss of abduction because the supraspinatus is still intact. This concludes our talk about the axilla. I hope you got the maximum benefit from this lecture, and thank you very much for watching.